Hello, welcome to Sonography Radiology Training Channel. This series of videos is about abnormal fetal growth. This is the second video in this video series with title of Fetal Growth Restriction and Small for Gestational Age Fetuses Part 2. In video part 1, the important prerequisites for diagnosis fetal growth restriction and small for gestational age fetuses were explained. In video part 2, it will be explained which tools are required for diagnosis, surveillance, and management of fetal growth restriction. So, the outline of these presentations include the tools for diagnosis, surveillance, and management of fetal growth restriction, include fetal growth velocity, Doppler velocimetry, rule of Doppler velocimetry in diagnosis, and biophysical profile scoring, cardiotocographic and short-term variation of fetal heart rate, and biomarkers. The first one is fetal growth velocity. There are several methods to evaluate fetal growth velocity, including use of longitudinal growth charts, assessment of deviation from growth velocity charts, and individualized growth assessment. Methods to evaluate fetal growth velocity and application of customized growth charts for this purpose are described in more detail in fetal biometry course videos, which I will put their links in the description section. Another section is Doppler velocimetry. The most important part in FGR fetus evaluation, which is related to radiologists, is Doppler velocimetry. In general, two items should be checked in the fetus: fetal arterial Doppler and fetal venous Doppler. Fetal arterial Doppler includes umbilical artery, middle cerebral artery, and uterine artery, and fetal venous Doppler includes umbilical vein, inferior vena cava, and ductus venosus. The first one is umbilical artery. The umbilical arterial circulation is normally a low impedance circulation with an increase in the amount of end-diastolic flow with advancing gestation. Umbilical arterial Doppler waveforms reflect the status of the placental circulation, and the increase in the end-diastolic flow that is seen with advancing gestation is a direct result of an increase in the number of tertiary stem villi that takes place with placental maturation. Diseases that obliterate small muscular arteries in the placental tertiary stem villi result in a progressive decrease in end-diastolic flow in the umbilical arterial Doppler waveforms until absent end-diastolic flow, and then reversed flow during diastole is noted. Reverse diastolic flow in the umbilical arterial circulation represents an advanced stage of placental compromise and is associated with more than 70% of placental arterial obliteration. Doppler waveforms of the umbilical arteries can be obtained from any segment along the umbilical cord. There are differences in Doppler indices of arterial waveforms obtained from different anatomic locations of the same umbilical cord, for example in the fetal insertion or placental insertion, but they are generally minor and have no significance in clinical practice. In 2013, the International Society for Ultrasound in Obstetrics and Gynecology recommended taking Doppler measurements from a free loop of cord for the sake of simplicity and consistency. Umbilical artery Doppler indices that are important for fetal growth restriction and SGA diagnosis include resistance index, pulsatility index, systolic-diastolic ratio. The second arterial Doppler is middle cerebral artery. The MCA is the most accessible cerebral vessel to ultrasound imaging in the fetus, and it carries more than 80% of cerebral blood flow. The cerebral circulation is normally a high impedance circulation with continuous forward flow throughout the cardiac cycle. In the presence of fetal hypoxemia, central redistribution of blood flow occurs, resulting in increasing blood flow to the brain, heart, and adrenals of the fetus, and a reduction in flow to the peripheral and placental circulations. This blood flow redistribution, known as brain sparing effect, and plays a major role in fetal adaptation to oxygen deprivation. The right and left middle cerebral arteries represent major branches of circle of bliss in the fetal brain. The circle of bliss, which is supplied by internal carotid and vertebral arteries, can be imaged with color follower Doppler sonography in a magnified axial plane of the fetal head obtained at the base of the skull at the level of the thalami and wings of sphenoid bone. In this plane, the proximal and distal middle cerebral arteries are seen in their long axis with their course almost parallel to the ultrasound beam. As such, the insonating beam, which is parallel to the vessel and thus has an angle of insonation of 0 degrees, will result in a measured velocity that accurately reflects the true velocity of blood in this vessel, because the cosinus of the 0 equals to 1. MCA Doppler waveforms obtained from the proximal third portion of the vessel immediately after its origin from the circle of bliss have shown the best reproducibility. The most important Doppler indices of middle cerebral artery include resistance index, and also the ratio between the MCA resistance index and umbilical artery resistance index is important. Another artery is uterine artery. Pregnancy is associated with physiologic changes at the level of the uterine vasculature, resulting in progressive decrease in impedance with advancing gestation. This maternal adaptation to pregnancy is thought to result from the trophoblastic invasion of the maternal spiral arterioles in the first half of pregnancy. Also, we can see the dilation of the uterine arteries and veins, their wall thinning, and finally the creation of AV shunts between them. The invaded maternal spiral arterioles are rendered maximally dilated and minimally responsive to sympathetic and parasympathetic systems. This adaptation is intended to ensure a sustained increase in blood flow to the uterus during pregnancy. The uterine circulation can be assessed by Doppler velocimetry of the uterine arteries. Each uterine vessel can be demonstrated by color Doppler as it crosses over the hypogastric artery and vein just before it enters the uterus at uterocervical junction. Pulse Doppler velocimetry of the uterine artery should be obtained immediately after the vessel crosses the hypogastric artery and before it divides into uterine and cervical branches. Doppler waveforms of the uterine artery obtained in the late second trimester of pregnancy, showing normal uterine circulation with increased end-diastolic velocity, implying low impedance circulation. The presence of a notch in the waveforms and a low diastolic velocity with an increase in the impedance index after 22 weeks of gestation characterizes an abnormal uterine circulation. A substantial risk of complication is noted in pregnancies that show an abnormal uterine circulation in the late second and third trimesters. Pregnancy complications include FGR, preeclampsia, preterm delivery, and non-reassuring fetal status in labor. Uterine artery Doppler indices, which are important, include resistance index, pulsatility index, and also cerebroplacental ratio. Now, fetal venous Doppler. Doppler waveforms obtained from central venous circulation in the fetus reflect the physiologic status of the right ventricle. A specific information with regard to right ventricular preload, myocardial compliance, and right ventricular end-diastolic pressure can be derived from Doppler follow studies of the inferior vena cava and ductus venosus in the fetus. Now, umbilical vein. After 15 weeks of gestation, the umbilical vein normally has continuous monophasic blood flow but becomes pulsatal with fetal breathing or in pathologic cases such as severe FGR or fetal hydrops. In this image, we can see abnormal flow with phasicity in the umbilical vein sampled near the cord insertion at the fetal anterior abdominal wall. Also note absent end-diastolic flow in the umbilical artery in this fetus with fetal growth restriction. In general, umbilical venous flow is assessed qualitatively as either continuous monophasic or pulsatile. Inferior vena cava. Inferior vena cava Doppler waveforms can be obtained from a coronal plane of the chest and abdomen. In this view, the IVC can be imaged as it enters into the right atrium joined by ductus venosus and left hepatic vein. The IVC can be studied at two locations: at the inlet into the right atrium or in the segment between the entrance of the hepatic vein and the ductus venosus. A good correlation coefficient exists between these two measurement sites, and the location that provides the smallest angle of inclination with the vector of blood flow should be chosen. Inferior vena cava Doppler waveforms are three-phasic in shape, with the first phase corresponding to ventricular systole, the second phase to early diastole, and the third phase to late diastole or atrial kick. This image shows Doppler waveforms of the inferior vena cava in a normal fetus in the third trimester of pregnancy. Note the presence of reverse flow during the atrial contraction phase of diastole. Now, ductus venosus. Ductus venosus Doppler waveforms can be obtained from a transverse view through the fetal abdomen at the same anatomic plane as the abdominal circumference. By superimposing color follow Doppler image on grayscale image, the ductus venosus can be identified as it branches from the portal vein. High velocity turbulent flow with color aliasing is commonly seen within the ductus venosus given its narrow lumen. The presence of aliasing on color follow Doppler image helps in identifying the ductus venosus in early gestation. This image shows color Doppler sonogram of a transverse plane of the fetal abdomen showing the umbilical vein and ductus venosus. Note the presence of turbulence with aliasing on color Doppler in the ductus venosus. Ductus venosus Doppler waveforms are biphasic in shape, with the first phase corresponding to ventricular systole, the second phase to early diastole, and the nadir of the second phase to late diastole or atrial kick. Note the presence of forward flow within the ductus venosus throughout the cardiac cycle. Blood flow during the umbilical vein carrying oxygenated blood to the fetus can be assessed either within the fetal abdomen or within the amniotic fluid. Reverse flow in the ductus venosus results from a decline and subsequent reversal in forward flow velocity during atrial systole. It may be due to worsening placental disease like placental insufficiency, impaired cardiac function secondary to metabolic compromise, or congenital heart disease, redistribution of hepatoportal blood flow through the liver, or a combination of these factors. The important Doppler indices of ductus venosus include preload index, peak velocity index, and pulsatility index, and systolic peak blood flow to atrial systolic peak blood flow ratio. Another important indices is mean velocity of the umbilical vein. What is the role of Doppler velocimetry in diagnosis of FGR and small for gestational age fetuses? The rationale behind the application of Doppler velocimetry in fetal growth assessment is that it can identify uteroplacental function through evaluation of the uterine and umbilical arteries. Uteroplacental insufficiency is putatively mediated through spiral artery maladaptation and alteration in the venous vascular tree. On the fetal side, Doppler velocimetry allows evaluation of the middle cerebral artery and ductus venosus as fetal cardiovascular adaptation progresses from hypoxemia to acidemia. A lack of physiologic transformation of the uterine arteries from high to low resistance vessels is thought to reflect inadequate trophoblastic invasion of the spiral arteries, leaving a high impedance circulation. The persistence of high uterine artery mean pulsatility index above the 95th percentile is associated with placental insufficiency and maternal vascular malperfusion of the placenta. Progressive increasing PI in the umbilical artery corresponds to progressive reduction in the placental surface area available for gas and nutrient exchange and increased fetal afterload resistance, and is associated with placental vascular insufficiency reflected by absent and, in the end stage phase, reversed and diastolic flow in the umbilical artery. Reduced fetal MCA pulsatility index is a consequence of vasodilatation, that so-called brain-sparing effect. This represents a hemodynamic response to fetal hypoxemia via direct vascular sensing of oxygen tension in the cerebral circuit, and in other vascular beds, a consequent redistribution of fetal cardiac output occurs preferentially to coronary arteries and adrenal glands. Alternation in the ductus venosus flow velocity waveform, especially absent or reversed A wave, are caused by progressive dilatation of the ductus venosus isthmus in order to increase the blood flow toward the heart in an attempt to compensate for extreme oxygen deprivation. Doppler velocimetry plays a central role in identification, surveillance, and management of FGR because it allows for the identification of uteroplacental insufficiency and/or fetal cardiovascular adaptation to hypoxemia. Importantly, the two phenotypes of FGR means early onset and late onset are corrected by different Doppler velocimetry patterns. Now, biophysical profile scoring. The biophysical profile score consists of the combined evaluation of fetal tone, gross body movement, breathing movement, amniotic fluid volume, and heart rate activity. This score can predict both fetal pH and adverse neonatal outcome. The relationship between altered this score and fetal pH seems to be consistent across gestational ages. A score of equal or less than 4 is associated with a fetal pH less than or equals to 7.20, while a score of less than 2 has a sensitivity of 100% for acidemia. This correlation remains highly significant even when using a modified biophysical profile that is based on assessment of only fetal heart rate and amniotic fluid volume. Now, cardiotocography and short-term variation. Cardiotocography is a continuous recording of fetal heart rate obtained via an ultrasound transducer placed on the mother's abdomen. It's widely used in pregnancy as a method of assessing fetal well-being, predominantly in pregnancies with increased risk of complications. A reactive test virtually excludes fetal hypoxemia. The fetal heart rate short-term variation is a biophysical parameter obtained by computerized cardiotocography that reflects autonomic nervous system function. In the context of FGR and the accompanying presence of severe hypoxemia or hypoxia, the fetal sympathetic and parasympathetic activity is altered, resulting in reduced fetal heart rate variation and thus reduced short-term variation. Computerized tests and evaluation of short-term variation have been validated against invasive testing in the fetal hypoxemia and acidemia, which is fetal scalp blood sampling, and represent only objective measure of fetal heart rate. Visual inspection of conventional cardiotocography does not provide the same information as computerized, as conventional form represent largely subjective assessment with low intra and intra-observer reproducibility. And the last section is biomarkers. Placental biomarkers have a potential role in screening, diagnosis, and therapy of placental disease linked to hypertensive disorders of pregnancy and/or FGR. Several placental factors have been investigated, including placental proteins as well as microRNA or mRNA. Some placental proteins, such as pregnancy-associated plasma protein A or PAPA, are biomarkers of placental function in the first trimester, though its predictive ability is limited. FMS-like tyrosine kinase receptor 1 is the most promising placenta-derived predictive biomarker for preeclampsia. The soluble FMS-like tyrosine kinase 1 to placental growth factor ratio has been proposed as a short-term predictor to rule out preeclampsia in women in whom this condition is suspected clinically. Although some reports suggest that use of this ratio might be helpful in the management of and differentiation between SGA and FGR, the lack of interventional trial data precludes the recommendation of these tests as an adjunct to ultrasound imaging. But of course, the rapidly evolving research-based discussion of the use of biomarkers in screening for SGA and FGR is beyond the scope of this guideline. Now, please pay attention to these final teaching points. Doppler velocimetry of the uteroplacental and fetoplacental circulation may be used to distinguish between SGA and FGR. Multi-modal assessment is recommended for the evaluation of pregnancies with suspected FGR. Computerized cardiotocography or biophysical profile scoring should be used in combination with Doppler velocimetry. Ductus venosus Doppler waveforms show forward follow throughout the cardiac cycle. Reverse diastolic follow in the umbilical arterial circulation represent an advanced age of placental compromise and is associated with more than 70% of placental atrial obliteration. MCA Doppler waveforms obtained from the proximal third portion of the vessel immediately after its origin from the circle of Willis have shown the best reproducibility. A lack of physiological transformation of the uterine arteries from high to low resistance vessels is thought to reflect inadequate trophoblastic invasion of the spiral arteries, leaving a high resistance circulation. Doppler velocimetry plays a central role in identification, surveillance, and management of FGR because it allows for the identification of uteroplacental insufficiency and/or fetal cardiovascular adaptation to hypoxemia. Although some reports suggest that the use of this ratio might be helpful in the management of and differentiation between SGA and FGR, but the lack of trial data for biomarkers precludes the recommendation of these tests as adjunct to ultrasound imaging. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.